We're going to talk about adnexal tumors, but first, this is my homework from my talk earlier. It's the reference that we talked about for whether or not moderately dysplastic nevi need to be excised or not. And in this, they looked at 467 moderately dysplastic nevi that were present at the margin. They followed for almost 7 years, and none of them recurred as melanoma. But patients who had multiple moderately dysplastic nevi had a higher risk of melanoma in other areas, but not in the scar or in the previous sites of their moderately dysplastic nevi. So they need to be watched a little bit closer. Okay. So now on to adnexal tumors. So adnexal tumors are complex and have overlapping features. I think the names are challenging because they all have overlapping, hydrofolliculotricholemomoma. They all start to sound alike. They're usually benign and are challenging because they can mimic other malignant diagnoses, which I will show you, which brings up an important differential diagnosis. And the malignant variants, which I'm really not touching too much today, but they look like the benign variants, have more mitoses, are larger, and tend to have a more infiltrative growth pattern. But they have the features that we're going to talk about for the benign variant. So if you can recognize those benign features, then the malignant then you can get to the malignant diagnoses, and they're exceedingly rare. So skin adnexal tumors derive from hair follicles and sweat glands. They can be confusing even for experienced pathologists. Partial sampling is always a problem, as it often is in DermPath, and they often don't fit neatly into well-established classification schemes, and sometimes you're left with saying on your report, benign adnexal tumor with a descriptive comment that says, I favor this or that. Okay, so the adnexal structures involved, I think it's important to remember what these look like because this helps you identify what type of tumor you're looking at. So hair follicles, we see lots of these. The more superficial portion looks like epidermis, and the deeper portion is mostly outer root sheath cells, and they are clear and have more of a tricholemal keratinization. The sebaceous glands sit with the hair follicles in the folliculosebaceous unit generally, although they can be alone in some areas. And you can see well-developed sebocytes with a bubbly cytoplasm, pycnotic nuclei, and a thin layer of basaloid cells around. Eccrine glands, deep in the dermis or subcutis, small, narrow lumen. I think of them as like a bag of worms or a bowl of spaghetti that's been cut on cross-section. They kind of wrap around each other.
All right, myxoid tumors. Myxoid tumors are hard, okay? As dermatopathologists, really all pathologists, we rely on pattern recognition, and myxoid tumors, because of the accumulation of myxoid stroma, makes the patterns more difficult to recognize, okay? But usually if you pay careful attention to detail, you can usually get a diagnosis. All right, an older man with a lesion on a calf mass clinically was thought to be a cyst or lipoma or something, and then a punch biopsy was performed. Not a lipoma or a cyst, I think we can safely say. And we can see this sort of myxoid stroma in here. And here we see maybe a few extra spindly cells here in this myxoid stroma. And some of those cells have atypia. Oh, there's some atypical cells in here with this myxoid stroma. And again, atypia, maybe cluster around a vessel here, and significant cytologic atypia. What's your diagnosis? This is a myxofibrosarcoma. Okay. Myxofibrosarcomas are one of the most common superficial sarcomas Typically presents in older patients. The thigh is the most common location. They tend to start out in the subcutis, but they can secondarily involve the dermis. Can involve the arm and trunk, and I've seen rare cases in the head and neck, so it can occur in that location too, but much more common on the extremities. They are very infiltrative tumors. They often extend, crawl along the subcutaneous septae and extend well beyond the clinically apparent tumor. They're myxoid tumors, often with this sort of lobular growth pattern. And at least when you're dealing with the low-grade end of the spectrum, the grade 1 myxofibrosarcomas, they tend to be relatively hypocellular, You have these hyperchromatic spindle cells with mild to moderate atypia, and you often have this prominent curvy linear vasculature in which the tumor cells like to cluster around, so they're not evenly cellular. You can see cells that have sort of vacuolated cytoplasm that can look a little bit like lipoblasts. Mitotic rate is often low in the low-grade ones. Pitfalls, sometimes they're CD34 positive, and I've seen people confuse these with superficially sampled spindle cell lipomas, for example. So here's a more classic myxofibrosarcoma, nice lobular architecture, this myxoid stuff going on in the subcutis. Here's another one, lobules of these myxoid areas in the subcutis. It's crawling along the subcutaneous septae here, going to the margin, they almost always do. Here again, atypical spindle cells, prominent myxoid stroma. Here's a less cellular one, but
this is a practical approach to soft tissue tumors, and I once used that as a lecture title, and the review that I got back was, you should have called this an impractical approach to soft tissue. It's like, well, that was a little insulting and a little harsh, but okay. And I think really they were just angry at soft tissue tumors, not me personally. So again, the idea here is not to take you all through the soft tissue tumors. There's so many, it's ridiculous. It's just like, if you get a pattern, how to approach it, what's the differential, what are the most useful markers, that's the kind of thing. The idea is not to make everybody here a world expert in soft tissue tumors. Actually, the greatest compliment I get when I give this lecture is, man, you make it sound so easy, and it's not. And so hopefully you'll leave this feeling like, oh, this is pretty approachable. And then when you get back and you get your first case and you're like, oh my God, throw up your hands. That seems to be what happens, but I'm hoping that's not the case. Again, stop me with questions. We can do this as we go along. And I always approach it this way. I never give lectures on, the only soft tissue tumors as a group that I talk about are lipomatous tumors. Everything else is pattern-based. Like if I were to give you a lecture on just vascular tumors or smooth, that's just awful. It's awful to give, and it's probably worse to listen to. So this is the approach. So these are the most common patterns you see, and this is just based upon our consults. And I found this to be true over doing this for 30 years. A very common one is the quote, I put this in quotes, and you'll hear why. You probably already know why. MFH-like pattern. That's the really nasty pleomorphic looking tumor. Okay, so we'll talk about that first. Then we'll talk about a pretty classic pattern in soft tissue, which are just spindle cell tumors. Cellular spindle cell tumors that make you think you're dealing with a sarcoma. Then we'll talk about myxoid lesions, which is everybody's least favorite topic. They're really difficult to manage, but I'm going to give you an approach which I actually do think is practical. Because not everything can be given a name. And that's one of the things that I will wholeheartedly admit. The last pattern I save for the end, because that's when you're almost ready to cry anyway. And that's the round cell pattern, but it's a really common pattern. We think of this as, oh, it's a pediatric tumor pattern. Yes, that's true, but you see it way more often in adults. So I think we're all going to see these round cell tumors. And so again, there's so many round cell tumors. It's just an approach to the round cell tumor. So again, stop me. So this is the first pattern I'm going to talk about. Everybody can look at this and say, well, this is a malignant tumor. Very pleomorphic looking. It probably looks like it's even got some atypical mitotic figures in there. And your first thought probably is,